Professor Mohammed Reza. Professor Mohammed Reza, sir, I request everyone to kindly mute your mics, please. So this evening, we have with us a galaxy of elite speakers, Professor Mohammed Reza, sir, who will be talking to us on liver transplantation. Dr. Paul Ramesh will be talking to us on cardiac transplantation, kidney transplantation by Dr. Edwin Fernando, and lung transplantation by Dr. Saumitra Sinarai. We warmly welcome all the elite speakers. I also welcome our President, Dr. Sendamil Pari, sir, for this meeting, and all of you who have logged in today, this evening, for this academic fiesta. So with no further delay, we will go into this program. So we'll start a program with a prayer by Dr. Rekha ma'am. Rekha ma'am.
IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I rely on thee.
Thank you, Rekha ma'am. May I now request our academic committee chairman, Dr. Jayaraman sir, to give his welcome address.
Thank you, madam. Very good evening. Warm welcome. Academic. Good evening, welcome. I request all the delegates kindly mute your mic. I request all the delegates. Yes, sir.
Please, admin, mute all participants, please.
Jagadishan, can you all hear us? Dr. Jagadishan, can you mute please? Pranav, who's Pranav? Can you mute please?
Chairman sir, நீங்களே மியூட் பண்ணுங்க சார் எல்லாத்தையும்.
Okay, sir.
Thank you very much, sir.
Just a minute, sir. 1 minute, sir. Just a minute. I'll unmute all the delegates. Okay, sir. Kanagavel, sir. Is it fine, sir? Kanagavel, sir?
Sir, you are okay, sir? Please
okay,
proceed,
fine,
sir.
Yeah. Good evening. Welcome to all the delegates and the stalwart speakers. I am Dr. S. Jayaraman. I am a chairman academic committee of Indian Medical Association. I am the senior consultant working in Apollo First Med, Billroth and MGM Healthcare as a pulmonologist. I am the immediate past president of IMA Chennai Villuvakkam Mayavaram. I am a chairman, Rotary Foundation, the Rotary Club of Chennai Medical Fraternity. So, first of all, I thank our state president, Dr. Sendamil Pari sir, and the senior office leaders for giving me this wonderful opportunity to spread the knowledge across our members and other doctors. So every month we have our academic committee webinar. Each and every time we are going to discuss a different topic. is a practical updated topic we are going to discuss. This month, we are going to choose the topic of organ donation. This is a very important need of our topic. So the lot of diseases will advance and they end with the end stage disease requiring organ. So this is need of the hour. We're going to discuss in detail about that. I thank our Pari sir for this wonderful opportunity to provide this platform to spread the knowledge across. And our immediate past president and Palanichami sir, thank you very much. And President-elect Dr. Abul Hassan sir, and our Secretary Dr. N.R.T. Tyagarajan sir, and Treasurer Dr. N. Alage Venkatesan sir, and today's Chairman of the Organization Donation Committee, he will be moderator, Dr. Kanakvel sir. So I thank you all for this wonderful opportunity. Academic Committee, we have Dr. V. Nandagopal, he is a pulmonologist from Coimbatore, and Dr. S. Rekha from Chennai, and Dr. K. Venkatachalam sir from Chennai, Dr. M. Sushila ma'am from Purvali High Road branch, Chennai, and Dr. M. Sinasamy sir from Bhavani Kumarapalayam, and N. Subramanian sir from Tirunelveli, and Dr. Sudha Ramakrishnan sir madam from Trichy. We have Organization Committee Chairman Dr. Kanakvel sir, Dr. K. Bhubudi is the co-chairman, Dr. Dhanamithran sir, he is from Chennai, and J. Rajendran from Chennai Ashok Nagar, and Venkateswara sir from Sivakasi, and Saravanan sir from Chennai, and Padmanabhan from Harur Uttangarai, and E. M. Ilayaraja from Kottavanar Kovil. So all the faculty, all the committee members, I thank you very much for your sincere thing. Each and every CME, we have a TNMC accreditation for CME credit points. I request all the delegates, kindly type your name, registration number, email ID, and mobile number in the chat box. Pay via online ₹100 in the following account: Indian Medical Association, AMS, account number 7526010001890. Bank of Baroda, Delhi branch. IFSC code is bar 0 10x. Character 0. Transaction detail after the screenshot to ima@gmail.com within 3 days of CMD. So this month we have a lifelong membership IMA offer from June 1st to June 30th. I request all the members kindly spread the message. Those who are not joined IMA, kindly request them to join. Kindly utilize this offer. And I request Dr. Sudha ma'am, please take over and do the further proceedings. Over to Dr. Sudha ma'am.
Thank you, Jayaraman sir. May I now request our President, Dr. Sendaval Pari sir, to give his address. Sendaval Pari sir, over to you, sir.
Respected Chairman, Academic Committee.
Sir, just a minute, sir. I mute everyone, then again I will unmute, sir. Sorry, sir.
Good evening to all. Respected Chairman Dr. Jayaraman, Academic Committee, Dr. Kanakvel, Chairman, Organ Donation Committee, Dr. N.R.T. Tyagarajan, State Secretary, and State Office Bearers, and the committee members of Academic Committee and the Organ Donation Committee. Today's speakers, Dr. Professor Gandhimadi, Member Secretary, Transan, Professor Muhammad Rela, a renowned surgeon of the globe, Chairman, Rela Institute and Medical Center, Dr. Paul Ramesh, a senior cardiothoracic transplant surgeon, Apollo Hospital, Professor M. Edwin Fernando, Professor and HOD, Department of Nephrology, Stanley Medical College and Hospital, and Dr. Soumitra Sinkarai, liver transplant surgeon. We are very honored by having such a renowned surgeons for the CME. So I would like to thank all the speakers of this day for their presence and for their lectures. I hope this CME will be more useful to the attendees for the proper understanding of various rules and regulations of the government for organ transplantation and protocols. What are the protocols we have to follow when dealing the organ donation procedures, and also different kinds of transplant surgeries we are going to know about it. So I wish this program will be a success one. My special thanks for Kanagaraj, Dr. Kanagaraj. He organized this wonderful program with the top most surgeons of the city. Thank you for the opportunity. Thank you.
Thanks a lot, President, sir. May I now request Dr. M. Kanagavel, Chairman, Organ Donation Committee of IMA TNSB, to address this gathering. Sir is a surgeon, senior consultant and faculty at St. Isabel Hospital, Chennai. He is a research scholar at Sri Ramchandra Institute of Higher Education, Chennai, and is a director of Gastro Pro Adyar Institute. So over to you, sir, Kanagavel, sir, for your address and then moderation of this program. Thank you, sir.
Thank you, madam. Respected President, President-elect, past President, office bearers, Chairman, Academic Committee, Dr. Jayaraman, sir, my fellow colleagues in the Committee of Organ Donation, especially Dr. Bhupati, sir, Dhanamitran, sir, Rajendran, sir, Venkata Subramanian, sir, Dr. V. Saravanan, Dr. Padmanabhan, and Dr. Ilayaraja, for standing hand in hand for making this program a possibility. Friends, the Organ Donation Committee responsibility was bestowed upon me by Dr. Sendamal Pari, sir, with one focus: the message of organ donation, the science of organ donation, importance of organ donation should reach every member of IMA in the Tamil Nadu state. With that vision in mind, we have already done 2 programs, both in Chennai, and the President has asked us to do programs on all zones of Tamil Nadu, which we are planning from the month of August, with the help of all fellow members. Friends, we have been leading for so many years as #1 state in the organ donation. Now we are marginally less than the Maharashtra state because of the COVID issues, which we are trying hard to look upon. Tamil Nadu can boast it is one of the best model of transplant which is available across the country as well as the globe, and the most transparent transplantation process is happening in the state of Tamil Nadu. We look forward to hearing the giants, the leaders, the trendsetters, and the role models in the field of organ transplantation. Ladies and gentlemen, the top authority for the transplant in Tamil Nadu, the TransTan, the Transplant Authority of Tamil Nadu, we have been partnering with them for multiple programs, and the member secretary and all the office bearers, the liaison officers, the team, everybody has been kind enough in helping us to conduct various programs. The member secretary, ma'am, Professor Kandimati Rajendran, my teacher, Professor of Anesthesia, and a well-wisher, is being available over phone or in person. In fact, anytime we ask her, we will do it. We will find a way to do it. That's the message we receive from them. The entire transplant team is quite energized by Madam's presence, and she has taken meticulous pain in streamlining the efforts and making it more and more transparent and accessible. Today, I have the honor of inviting Professor Kandimati ma'am to share the organ donation vision for Tamil Nadu in the upcoming years. Kandimati ma'am, can we hear you, please? Madam? Ma'am? Okay, I think Madam is available in the group, but then can I request Professor Rela sir to give his talk on enhancing lives with liver transplantation. To introduce Professor Rela sir, he has a humble beginning, and later on he moved to a very global eminence, and then he has been bringing back the glory to the soil where he was born, and he has mapped Chennai to the global map of transplantation. And then he takes personal care, and he has multiple records of transplantation. The youngest is a very young child, and the longest survivor is already a lawyer by profession. And he has operated on multifaceted personalities, and a generation of transplant survivors are already existing across the globe. Man who is known for his humbleness, who is instrumental for bringing transplant to the reach of every government hospital, and his team relentlessly works to take the science of transplantation across the country, across the globe, and they have been always kind in providing their expertise whenever any center needs it. And then they personally and meticulously take care of the entire science of transplantation, both at basic level and advanced level, being transmitted to the next generation the best possible way. Sir himself has been author for more than 400 journals, 400 publications, and as of now, he has crossed 4,500 transplants directly involved by himself. He continues to teach at the King's College at various hospitals. Ladies and gentlemen, can I have the honor of having Professor Rela sir to share his views on liver transplantation? Professor Rela sir, please.
Thank you. Thank you, Dr. Kanagavel, for the kind introduction and also personally coming to invite me. And I also want to thank the IMA Tamil Nadu branch, its president, Dr. Sendamil Pari, as well as the academic chair, Dr. Jayaraman, for this invitation. I think this is an important webinar that you're conducting. I'm going to share my screen. Tell me if there is a problem. Can you see me?
Sir, you're good to go, sir.
Yeah. You can see my screen now?
Yes,
Full
sir.
screen,
Yes,
sir. Perfect, sir.
Yeah. The title given to me was Enhancing Lives with Transplantation, or Liver Transplantation, Enhancing Lives. I think the best way we can talk about organ donation and is to convince people that transplantation works, and everybody knows that kidney transplantation has worked for many years. Liver transplantation is the second one to come, and probably 10 years ago, the people wouldn't have been very convinced about liver transplantation. And I would say in the last 5 years, I think liver transplantation has become extremely popular in India. Now, cardiac transplantation, lung transplantation, heart and lung, pancreas are all slowly getting their feet, and the numbers are increasing and many lives are being saved. Now, I thought Dr. Gandhimati madam was going to talk about organ donation and give an introduction. I don't know if she's going to connect up, but I'm not going to give a huge amount of data. I went into transplantation now 32 years ago at King's College Hospital. Mainly it was a cadaver liver transplant in the Western world. It still is very much a cadaver liver transplant. I became a consultant surgeon in 1994 and then a professor of liver surgery there. And I was also in charge of HPB. In my life, I've really seen and worked with some of the top people. I personally knew Professor Roy Khan, who was supervising some of my research, and met Professor Starzl, who really was the first founder. And I was fortunate enough to go to an institution, King's College Hospital, which was run by Professor Roger Williams. He's there. And in addition to that, King's was well known for liver diseases in children. And this was Professor Alex Morwitt, with whom I worked for about 10 years. He's no more. He actually died while giving a lecture in South America on pediatric liver diseases. Now, very quickly, I took an interest in organ donation and increasing availability of organs for people. And I worked in an institution where there was a large number of children requiring transplantation. So one of the problems in the early days, 32, 33 years ago, when I went into transplantation, the outcome of transplantation for children was not very good. So, and they had to wait for a size match organ because it was all cadaver liver transplant. And to get a size match organ for children is really a very major problem, because many children were dying on the waiting list. And at that time, really, the procedure called split liver transplantation came up. The split liver transplantation concept was to divide a liver into two, use a small segment into a child and use a large segment for an adult. And this really paved the way for all developments in transplantation, including living donor liver transplantation. When a partial organ can be used for a child and an adult, the disadvantage at that time was the adult, because the adult could have taken the whole liver without much complications. So it was convincing the adult patient to receive half a liver, which was the most difficult in the early days. And we were able to really demonstrate that the outcome of split liver transplantation was as good as if the adult received a whole liver transplant. And when I published our data in Annals of Surgery, this is almost I think this was published in 1998, 25 years ago, we were able to show that in the King series, which was one of the largest at that time, with 41 patients, and this is a combined series of 98 patients from all over Europe, of which our patient was 41, we were able to show a 90% survival for patients who were receiving split liver transplant. The other interest I had was really transplantation for very small children. And when I went into King's, again, I told you the outcome of transplantation for small children, particularly when they were less than 5 kilograms in size, was very poor. And we really developed techniques. As you can see, if you put a large liver into a small child, you won't even, you can't even close the abdomen of these children. And the earliest publication that we did in the early phases, there was a 50% mortality when the children were less than 3 months of age. This is a single-center experience of children transplanted under 3 months of age. And this was a problem that we were facing. This is a disease called neonatal hemochromatosis, where children were born with a genetic disorder with liver failure, and they would die within 2 weeks of life. And to offer an organ for them, an adult organ for them, was a huge difficulty. And this is one of the problems that we had. Once you put even the left split liver, left lateral segment was too large for these children. So really, I developed techniques for reducing these livers into a very small liver, into a single segment out of the 8 segments, and transplanting this, and immediately the outcome improved. The next 6 children who received a monosegmental transplant, only 1 died, and we had an 85% survival. And this really became popular. As you can see, a single segment of liver from this liver was actually not from an adult. This was a 12-year-old donor, a child who died from a road traffic accident, and 1 segment of this liver was transplanted. As Dr. Kanagawel said earlier on, the youngest liver ever to be transplanted, 5 days of age, was transplanted by me some 25 years ago now, 23 or 24 years ago. This was the press conference done at that time. I felt it was important for you to see the press conference, because the mother pays tribute to the donor, and the donor family do not know. They do not know who the donor family is. And the first thing that this video is from 25 years ago, and this is a child who was transplanted at 5 days ago. I don't know if you can hear. I'm going to allow the mother to speak.
We can't believe it happened, and we're just overwhelmed with the whole brilliance and miraculous outcome that has occurred. And first of all, the donor, because of the anonymity of a donor, it's impossible to thank them. And we'd like to just give our heartfelt gratitude to donors of all organs, not just babies and
so this is a tribute paid to the donor by the family and a donor family that they did not know. And that was young me at that time at the press conference. And this child is now 24 years old. I've had longer survival than this. And I happened to meet her about 3 years ago when I went to King's, 4 years ago when I went to King's, and that's her with my colleagues, pediatric colleagues, Anil Dhawan and Georgina, the pediatric hepatologist, and she came for a clinic. And she's never had a CT scan ever since she's had a transplant. and she's on very, very low immunosuppression. She refuses to have any scans done because she's completely normal and doesn't even want to know how the liver looks. And I won't be, this is the child who had the monosegmental transplant. And this is me meeting her 20 years later. And I wanted her to come to India to promote organ donation. So 4 years ago, she came to India. We have this meeting called Masterclass in Liver Disease every year, which is attended by over 1,000 people from all over the world. And she came there because I felt that to show people, because everybody is skeptical when you transplant a very small child, the family wants to know, how is this child going to be? How long will this child survive? Will it survive 10 years? Will it survive 15 years? What other complications are going to happen? And for a girl like that who was transplanted at 5 days of age to stand in front of 1,000 people and say, I've never had a scan done in my life since the transplant, and I'm a completely normal girl. She was a law student at that time, but she's now working as a lawyer. And that was enough information for me to give to the public how well transplantation works for people. In fact, we had a meeting in the evening, and the government at that time felt that it was a good opportunity for them. I didn't have any plan to meet the chief minister. He heard the health minister attended the earlier evening function, and he wanted to bring the chief minister to meet her. This is one example of where the chief minister himself wanted to come and promote organ donation. And he came and honored that girl and gave her a bouquet of flowers the next day on that meeting. So it is stories like this which is going to tell the world that transplantation enhances life, transplantation transforms people. And after working for about 25 years in King's College Hospital, I decided to come back to India and to set up. And one of my friends was Dr. Ravindranath from Global Hospital. He said that there was an opportunity to India to do good quality work. And I felt that I should try that. And I came on a sabbatical. And liver transplantation at that time wanted me to write an article on the possibilities of liver transplantation in India. And I felt that at that time, after doing some research, that there was a huge opportunity. For transplant, the conservative estimate for liver transplantation is about 100,000. 1 lakh liver transplants is a requirement for India. We are currently doing about 3,000 to 4,000 liver transplants. So I'm going to say to people, whoever wants to do and come into the field, there is still a huge opportunity, and there are going to be more number of centers required. There are more organs that are going to be required. And there are many patients still dying without organ donation and transplantation. And we have had to develop living donor as a possibility. And living donor obviously is possible for kidney and liver, but it's not possible for heart and lung. So we need to expand the donor numbers. And as you all know, hepatitis B and C is declining, but what is on the increase is fatty liver disease. I'm sure most of you who are sitting here will know that if you're overweight and if you have an ultrasound, you're going to have a fatty liver. And it's such a common thing. And in a proportion of these patients, it's going to progress to cirrhosis. And in some patients, it may even progress to hepatocellular carcinoma. So that is going to become probably the #1 cause of liver transplantation, because this is a lifestyle disease, and overeating and obesity has become a major problem, which was a problem in the West and the United States is becoming a problem in our country. Now, what about India itself, and where do we stand? Actually, you'll be surprised to know that India stands #3 in the world in terms of organ donation and transplantation. We are not lagging behind. I mean, part of the reason may be because we have a very large population. The largest number of transplants are being done in the United States. Next is China and India. We know that India has overtaken China in the population, and I wouldn't be surprised if China overtakes United States and ultimately India overtakes China. And it won't be too long before India becomes one of the largest countries in the world offering liver transplantation. And when you think about liver transplant centers in India, the numbers are increasing everywhere. In Tamil Nadu itself, I'm sure there are about 25 liver transplant centers. However, probably only about 5 or 6 centers are doing more than 150 to 200 transplants. Most of the centers are doing less than 20 liver transplants around the country, but I'm sure that the many other centers will start doing large numbers. As I said, I returned back to India really to contribute first of all, and also to look at the opportunities, because I'm a very technical surgeon and I'm interested in innovations, and I'm currently working on robotics in liver transplantation. And living donor liver transplantation was not something that you can develop in the Western world, which has a very established cadaver program. But after coming here, I realized that both living donor and cadaver liver transplants have to go side by side. And I worked in global for 10 years. And then we moved to this institute, which is Rela Institute, where people think that this is a general hospital, 450 bedded, but our focus is mainly organ transplantation. And we have one of the largest liver transplant programs in the world now. Last year, I did close to 300 liver transplants. And we also have a very large pediatric liver transplant program. I have a large liver transplant team with about 36 consultants and over 100 nurses. So the large team moved with me from Global to King's College Hospital, from Global to the Rela Institute. And we have really set up something when people from the United States and the European countries come and visit us. Our facilities are actually better than most of the facilities that you can find in other countries. This is our liver intensive care unit where there is a one-on-one nurse and every patient is individually managed. I came here about 12 years ago. This is last year's statistics, and I performed over 2,000 and currently probably 2,700 liver transplants in India, probably 2,000 liver transplants in the UK. And our survival figures are actually not inferior to anywhere else in the world. And the overall survival for both adults and children is more than 90%. As I said, the number of pediatric liver transplants we do, last year we did more than 100 liver transplants. We have completed now more than 600 pediatric liver transplants. I think there are only 2 centers in the world who do more pediatric transplant than us. And both of them are actually in China. And we are the 3rd largest pediatric liver transplant center in the world. And it really changes these children's life. I mean, I gave you an example of an Irish girl transplanted at 5 days of age. But in our country, you can see this is a girl, a child 6 months old with biliary atresia, looking miserable with a very distended abdomen and dilated veins. And that's the same child 3 months later. So liver transplantation really transforms the lives of the children. And when we completed, and the youngest child I've done in India is about 42 days of age, who's done very well. This is a child from Bangalore who was transplanted at 42 days of age. And when we completed 500 pediatric transplants, now we have completed 600 pediatric liver transplants. We had our health minister and our minister, Dore Murugan as well there, you can see in the background. And these are all children who have had liver transplant. Everybody wearing a white t-shirt is a child who's had a liver transplant, and you will never be able to tell by looking at them that they are actually sick or somebody who's had a transplant. So we have got more than 500 children, and we have the huge opportunity in Tamil Nadu, where this is the only state in India which not only promotes organ donation, but fully funds transplantation. No other state in this country actually funds transplantation. The government pays 18 lakhs for every transplant done in the private sector or in the public sector. And that is a huge advantage for the population in Tamil Nadu. And I say, if you do good work, you get the recognition. I've had the Lifetime Achievement Award from the Tamil Nadu MGR University, and I've had a DSC honoris causa as well from the previous chief minister. So it's not that I'm politically connected, but good quality work is always well recognized. And I want to really thank the work that I've been able to do in India. 2 years ago, I became the president of the International Liver Transplant Society. And I say to people that if I was continuing to work in UK, I would have never become the president of International Liver Transplant Society. There has been no Asian president of this society so far. I'm the first Asian president of the International Liver Transplant Society. Actually, there has not even been a UK president. I'm actually a UK citizen, so I'm the first UK citizen to become the president of International Liver Transplant Society. So good work comes with good recognition from all over the world. And India, as I said, has become prominent in the field of liver transplantation around the world. Apart from me, there are many, many people in India, in our country, who are becoming prominent, and these are all council members, or they are part of a membership of various committees of International Liver Transplant Society in India. And India now is very well represented throughout the world. And when I returned to India, people said, you will not be able to do research in India. But I have been able to continue to do research, both clinical as well as basic science research. We have a lab as well, a stem cell lab, and I have more than now 700 publications, and I have an H index of 70 or more than 70. And ILTS has come to India, and last year we had a consensus meeting of International Liver Transplant Society, where almost all of the top surgeons from anywhere in the world were there in Chennai for this meeting, and we had 4 publications which are coming out in the journal Transplantation out of this meeting. So this was a consensus meeting on living donor liver transplantation conducted in the ITC Chennai last year. So India is becoming very prominent and highly academic in the field of liver transplantation. And in addition to that, I want to say, I've always been keen on surgery. I've always been keen on academics, and Grey's Anatomy asked me to write a chapter on the anatomy of the pancreas. And for the first time, Bailey and Love introduced a chapter on liver transplantation in this edition. That's the first edition where there is a chapter on liver transplantation, which has just come out. And they've asked me to write that chapter in Bailey and Love on liver transplantation. So again, to say that recognition comes with good work. And finally, to finish off with, I think improving organ donation, I can see for increasing public donation. Dr. Gandhimati is there. I'm sure she's going to address a lot of these points. Public education and profession, educating people, the doctors, is the most important. Political will is there in our state. We are lucky. We have got both the political will and the political and funding. New units need mentoring from larger units, and there needs to be an association with private-public partnership. And I'm very pleased to say that all of this is happening. And finally, really, the best way to promote transplantation is to show how well patients are doing. And for that, we need public confidence and professional confidence in us. And for that, we need really transparency, outcome data available, registries to be produced. And as the president of ILTS, we are now actually launched in a big way a living donor liver transplantation registry, which is supported by WHO as well. Actually, this launch of the registry is now published in the Nature journal itself, who have agreed to publish that, and that has just come out as an article in the Nature journal. So finally, to say about public-private partnership, we have had an MOU. I've had an MOU with the previous government as well, when I was in Global, where we started the living donor liver transplant program in Stanley. And you can see that most of the donors have come from private hospitals, but more recently in 2022, the number of organs in the public hospitals also increasing. And I think if the public hospital transplant numbers go up, then the donation in public hospitals will also go up. And I'm very pleased to say that the program we started in Stanley, we have done 43 transplants since our program took over or started helping the Stanley program. And we have only one mortality out of the 43, with about 97% survival, which is even better than Western standard survival, really. One of the best survivals you can think about. And we've also started doing this year, we have started doing liver transplantation in Rajiv Gandhi Government General Hospital. We have now, in the last 3 months, we have done three liver transplants, and all three patients have done extremely well. So I'm pleased that I've been able to contribute. I've been able to put really Tamil Nadu on the map in terms of liver transplantation. There is a huge recognition from all around the world for the work we do. And I'm also thankful for TransTan, and I'm thankful for the government of Tamil Nadu for the support that they have lended us. And I'm grateful that I've been given the opportunity to help the government sector to perform better in liver transplantation. Thank you very much.
Thank you, Professor Rela, sir, for giving a very important perspective of the organ transplant. And we are thrilled to see the amount of transformation it brings to the younger generation. And we are very pleased to know as young as 48 and 3-day-old kids are given the option of the best of the science. I wish to invite comments from the state president. Dr. Pari, sir, your comments, please.
Very nice talk. Really, Dr. Rela is a multifaceted man. Not only a doctor, he is a poet, writer, and orator. Very good orator. He is well versed with Kambaramayanam and Tirukural. It's a very great personality. This is his life history. He is one of the example for the surgeons, particularly in the liver transplant. Okay, we admire from outside. We are following Dr. Rela from outside. He's stallion. My next to my batch. It's a 75 batch. I'm 74 batch. So very glad to attend the CME and hear the lectures of Dr. Rela. Thank you very much, Dr. Rela. Thank you.
Thank you. Thank you very much.
Gandhimati ma'am, would you like to give your comments before starting your talk? Ma'am, unmute, ma'am. We are unable to hear you, ma'am.
Yeah. So,
Madam, we are unable to hear you.
you can't hear me?
Yeah, now it is coming up, ma'am. Yes.
Can you hear me now?
Yes, ma'am.
Okay. So, yes, as Professor Rela has been telling, I've been, they are doing the most number of liver
Sir,
transplants.
not well audible, madam.
Not audible?
Yes.
Okay. I'm coming nearer to the mic.
Yes, now it's
Now
clear.
can you hear me?
Yes.
So yes, as he was saying, they have been doing the most number of liver transplants. They do almost, I think, 24 or 23 per month because we collect the statistics. And live transplants. Of course, cadaver transplants are also being done. And they have been helping us out, as he has been saying, in starting off the program at Rajiv Gandhi Government General Hospital. So he's also going to help us out with 3 more colleges, Coimbatore Medical College, Tirunelveli, as well as at Madurai, where they have already started registering patients. So, sir, your help will be needed there also. I think you put an MOU with them also. And so I think he has spoken everything, and there's nothing much to add. Last year, we have given him an award and also an award to his institute for the best performance in liver transplants from the government side. Thank you.
Thank you very much, ma'am. IMA Tamil Nadu gives the best wishes to Professor Rela sir and his units for contributing immensely to the service of humanity, as well as making India as the top-notch performer across the globe. We congratulate you, sir, on all of us here for being elected as the president of IATS. And we wish India takes more higher strides and India becomes a nodal center for global experts to come in for training and learning research. Thank you, sir. Thank you for a valuable time for contributing your insights on the liver transplant. On behalf of everyone and the doctors assembled here, I wish this message is taken to all your IMA members branch. And I'm sure if a child or an adult is touched with this information, I'm sure the family and the society around that person is going to transform into a totally different growth potential oriented society. Thank you, Professor Rela, sir, for joining us today. With your permission, we move on to the next talk. We wish you could stay as long as with us.
I will.
Professor Gandhimati ma'am, who happens to be my teacher, and we know each other for more than 30 years now from the dates of Madras Medical College. And she is a very eminent anesthesiologist. I would say in one line, she never refuses any case for any reason. I don't know, but I would definitely use this forum to tell the statement. The one word she uses is, if we are going to refuse, who else is going to help these patients? That's the one statement.
Yes.
So I wish all the doctors here and the medical fraternity takes this message. What possible by a medical fraternity should be done at the right time, at the right intensity, and with the right intention. Ladies and gentlemen, she is spearheading the entire coordination efforts of TransTan activities. She has made everything transparent. I wish all of you visit the TransTan website and take the organ donation pledge. Today, let us welcome Dr. Kandimati ma'am to share her viewpoints and her vision for the organ donation in the state of Tamil Nadu for the upcoming years. Madam, over to you.
Thank you, Kanagavel. Hope I am audible. Am I audible, Kanagavel? So thanks for the introduction. Thanks for introducing me as an anesthesiologist. Yes, I always say that nama pannalena RGGH la pannalena patient enga pogum. That is a question I always ask or I think before I cancel a case. So thanks for that introduction. I will be speaking a few words about TransTan. I'm sure that many of you do not know what TransTan actually is. So TransTan means Transplant Authority of Tamil Nadu. And here I will be telling you a gist of the TransTan functions. And then later on, I will talk about the challenges faced over the years and how it has been overcome. And what is the vision for organ donation or for TransTan in future, how we can improve ourselves. So now going on to how it was started. TransTan was started as a cadaver transplant program way back in 2008 by the then Honorable CM, Dr. Kalinga. And later on, it was made into a government society, Transplant Authority of Tamil Nadu in the year 2015. So the main functions, what we do at TransTan is, our single most important function is to maintain patient registry. Patients, by patients, I mean end-stage organ failure patients. So we have an organ-specific registry, based on which we make equitable and a transparent organ allocation. And we create awareness among the general public. We go across all societies, that is from school level, college, private firms, and to medical colleges, to our own paramedical people, and also to the common public on the road also, and to the police personnel. So that is a major work that we do. Then of course, statistics and data. And we collect all the post-transplant outcomes pertaining to this program. Then another thing we do is coordinate with the state government as well as with the central government. And we are also the regional head for the 7 southern states south of Maharashtra. And we coordinate and do the organ allocation whenever there is organ sharing among these states. So we have both private as well as government hospitals which are registered, licensed and registered to do this disease donor program. And out of which there are 127 private hospitals, all are transplant hospitals. And government hospitals, all our 36 government hospitals have been licensed last year and to do this program. And 13 of our government hospitals, I'm proud to say that 13 of our government hospitals do not only kidney transplants, but also liver as well as heart and lung transplants. And the rest function as the rest of the hospital. They are the new medical colleges, which function as just organ retrieval centers. They are non-transplant centers, but they are organ, that is what we call as NTORCs. So, and the protocols and guidelines that are followed for organ allocation is based on the Transplantation of Human Organs Act of 1994. This was amended in the year 2011. And of course, we have various government orders for declaring brain dead and the procedure to be adopted by private and government hospitals. So what were the challenges faced over the years? Professor Rela himself was talking about transparency. Yes, always transparency in organ allocation is a question. When it was started as a cadaver transplant program earlier on, the organ allocation was done through phone calls. So then after which came SMS, after that mails, emails, through emails. And only in 2018, a WhatsApp group was started for the purpose of organ allocation. And then now we have moved on to an automated online process of allocation, about which I will be talking in the coming slide. And of course, there were a lot of apprehension from the hospital side about their database, whether it was secure, the patient database. And coming to streamlining the patient registration, one single patient will register in many hospitals. There will be more than a single patient will get registered in many hospitals because they will be desperate to get an organ. So எங்கேயாவது கிடைக்காதா organ in some hospitals. So that is how it was happening. And this we found out when we were doing a random check in 2019, and we ended up deleting almost 1,800 patients from our list because of multiple patient registrations. So that was a major work. And of course, streamlining this allocation process, we keep on streamlining change of protocols and so on. And improving disease donation in the government hospitals. This has been a major challenge, which I think partly we have overcome. And documentation and statistics earlier on was manual. So as each case gets over, we used to document it and then do a manual statistics and so on, which has now changed. And to break the myth among the public regarding organ donation. Because as you all know, most of our movies or even any program on TV or media, they show organ donation as something, the dark side of organ donation, whereas the real altruistic thought of organ donation is lost in the process. So what were the steps taken by the government to overcome these challenges? So to bring about more transparency, to have a secure database, and for streamlining the patient registrations and process, and for easy documentation. So we brought about the automated webcam app, which is called as Video. This has been a real boon for us. This was launched by our government in the year 2021. So 2 years down the lane, it has made things so easy for us. I'll be talking about this in the next slide. Then of course, the government hospitals, we from Transtan, we go to all our government hospitals all over the district to sensitize doctors regarding donation and the procedure to be followed about brain death and how it has to be certified and so on, and all the protocols. And all our new medical colleges also, which have just come up in the last 1 year, have been licensed. So these two things, that is this donor action program in all our government hospitals, has really increased the pool of organs that are available for our government hospital patients, because when a government hospital gives a donor, the first preference is given for the government hospital. Only when we do not have a suitable recipient in any of the government hospital, it goes to the private sector. So even in today's Hindu, there was a nice article that mentioned about that government hospitals are doing very well, and it has really increased. Last year, the number of donations since last year to till date, the number of donations from our government hospitals and from our new medical colleges, NTORCs, has been 78 as of yesterday. And they have done almost 268 transplants have been done in our 13 government hospitals. So this is really, in all these years, this has been the high last year and this year as of now. So this is really heartening to note. And awareness programs at the district level, this is done by our coordinators, transplant coordinators, who are appointed by Transplant at various district levels. They go to the interior villages also to talk on organ donation. Now about this VDL, that is automated webcam app, this anyone you can just go to Play Store and download it also. There's both Android as well as iPhone, it is compatible. So this is here everything has been made automatic. The patient registration is totally automated and online, and the wait list is dynamic updation of wait list. And I was talking about multiple patient registrations, which we have operated by the use of Aadhaar authentication. So even this is, we have even the iris identification as well as fingerprinting can be done for patients who, if there is any problem with authentication through their phone number. So, and we have brought transparency to the patients also in the form of they get SMS notifications once they are registered. When they request for a transfer from one hospital to another hospital also, that is also informed to them. They can go and check their wait list and their current status on the wait list. So all this we have done, and it is and once we start a case, earlier on we used to make almost 100 to 200 phone calls from Transstand to various hospitals who are on the seniority. So to tell them that there's a donor alert and whether and asking them whether the patients are ready and whether they're willing to take and so on. But now all those things are done with. We have brought about automated calls through this VDL app as well as mobile notifications. So it has made work very easy for us. So as well as easy document upload for both the donor hospital as well as for the recipient hospitals and also for us. And earlier on, when we were doing it with WhatsApp organ allocation, when we do more than one case, sometimes we have done 3 or 4 cases. In such cases, what happens is there's always a confusion for which donor we are putting up the priority listing. So there has always been a confusion. But with this app, each case has a separate pathway, so we can just go and check on it. And it has made things so easy for us. It's time saving, it is user friendly. We have a secure patient and hospital database thanks to this app. And with just one touch, we get the entire report generated about one case. Whereas earlier on, we used to go and check on the WhatsApp, take out the WhatsApp log, the SMS log, the call logs, and then we used to put a separate file for each donor. So all that has become easy for us now. So what is the future vision? I think the 2 main important things what I was talking about, one is app, and then the government hospitals doing well. This was a big challenge and which we have overcome to a certain extent. And we can bring more transparency to the patient in future, like if the patients who are on the priority, once a donor alert comes, they can be sent a notification. So that we have to think twice before we start doing that. And then we are now doing awareness program to prevent end-stage organ failure. We are always talking about organ donation, but what about the end-stage organ failure patients? Prevention of organ failure. So now we are doing that also. And then we need to do more of hands-on training workshop for transplant procedures for the transplant teams. And also, we have started doing some short films to convey the real altruistic message of organ donation. We need more such films to show the better part of organ donation and not show it as an organ trading. And we are now in the process of starting this organ donation as a topic in our college curriculums. Already one college at Trichy has started that curriculum, and they are doing some research also. They are doing some studies also. We have been approached by them for various such activities, and hopefully, I've been hoping every year. I hope we are able to get government-run air ambulance services. Hopefully, in future this will be possible, and because it is I know about the heart and lung transplant teams and the patients. They spend almost, sometimes it goes even up to 20 to 22 lakhs to bring organs from some other state. So I think this should happen in future, air ambulance services. Hope it happens. So thank you very much. I thank the IMA members for having all of you on a Sunday night. I think there are more than 90 people here, and I thank Kanagare. Thank you very much.
Thank you, ma'am. I'm sure the future of organ transplantation in Tamil Nadu is so meticulously planned, and I'm sure this will be giving a more concerted and more oriented effort. I wish and also pledge on behalf of IMA that IMA will take this message to the grassroots of all the practitioners. And of course, there are many people who own hospitals who can effectively get these things as a contribution, as a beneficiary, or as a spreader of this message to the right team at the right time. Thank you, ma'am. Thank you for sharing your viewpoints. And I look forward for more collaborations. We look forward for events, 3 more events in this year across the state. We will keep in touch, ma'am. I will drop in to discuss and take it further. Thank you for joining this evening, ma'am. Thank you very much.
Kushal asked him to send a written request.
Friends, now with the ongoing CME effort, we are going to move to the next aspect of the CME. We are having Professor Paul Ramesh. He is going to speak to us on cardiac transplantation, newer paradigms. Professor Paul Ramesh is an eminent cardiothoracic transplant surgeon, and he is a son of the soil. And he has graduated from Madras Medical College, then moved out to the UK for his FRCS. Later on, and as Professor Rela, he has also come back to India for providing the transplant services in India. And he has one of the largest transplant volume, and he has been in this field for now more than 32 years. He also specializes in intra-arterial thrombolysis and specific non-invasive cardiac valve replacements also. Ladies and gentlemen, I have the honor of inviting Professor Paul Ramesh to give his viewpoints on cardiac transplantation status in India, how the paradigms are changing for cardiac transplant. Over to you, Dr. Paul Ramesh.
Thank you very much. I hope you can hear me. Thanks to Dr. Kanakavel and the IMA. So I have been asked to talk about new paradigms in heart transplant, and this has a great relevance in both organ utilization as well. So if I can just start, I'll share my, can you see my slides?
Not yet, sir, not yet.
Okay, 1 minute.
I would like the views of all so that we can have a concurrence. Because normally
recording in progress.
Normally the tradition has been that we always give it to somebody who's doing a colorectal work or dedicated to colorectal.
Is that possible? Okay, that's great. Okay. Let me just, yeah. Okay. The reason why I think this is very important, I'll go on to my first slide, is the concept of a transplant window is very important. This is of great importance in heart and lung transplants, but has a relevance in kidney and liver transplant as well. So here, it basically means, is the patient or the recipient being too early being pushed into a transplant, or is it that they are too late and they've had multi-organ failure? So I'll tell you some of the reasons why we need to discuss this is because getting a patient in a transplant window is ideal for the recipient, but is also the best way to use organs properly. Or you're using organs too early, which means that you're constantly saying there are not enough organs, or you're giving it to patients who are not able to get out of the transplant, which essentially means you're wasting the organ. So it's quite important to define this transplant window. And this has also changed. The new paradigms in heart transplant is that what we would consider a normal transplant window in the past, and I've been involved in being trained in transplants from Cambridge from 1997, 98, so almost coming up to 25 years. Significant changes have happened in this particular area. The other thing I want to emphasize today is, just as now all the general practitioners are very adept and very skilled at managing diabetes, similarly, a skill like that should happen for heart failure. Both risk stratification as well as medical management, as well as vaccinations, physical rehabilitation, as well as nutritional rehabilitation can all be done very well by the general physician, probably far better than a cardiologist or a heart failure center, because they are more in tune with what's happening to the patient. And this singularly can improve the amount of time that a patient, even diagnosed with cardiomyopathy, can be kept away from having a transplantation. And this is very, very important. So we can make this transplant window narrower or extend for them, so that they don't end up having a very early transplant. And I'll touch upon a few of these in the next few minutes. Yes. Just a minute. Why is this? Yes. So what is too early? So this is quite important. And I think Dr. Kantimati has clearly pointed out this is one of the important things that Transplant collects before they list a patient. Prior to somebody being actually confirmed as irreversible organ failure, only if an organ is irreversibly failed should it be transplanted. If any organ has reasonable tissue function which can be maintained, then they are not candidates for transplantation. Okay. Optimal medical management is not reached. This is very, very important as far as heart transplant is concerned, because heart failure, 25 years ago, there were about 2 medicines that you could give. You gave them Lasix and you controlled their blood pressure. Maybe you gave some beta blockers, you gave them Digox, and that was it. But with the improvement of different generations of ACE inhibitors, ARBs, MRAs, the introduction of Viamada as a combination neprilysin inhibitors, as well as the sodium glucose transporter inhibitors, have all improved the prognosis of heart failure patient, both in terms of longevity as well as in quality of life. But that I mean, patients in NYHA 3 and 4 moved down to NYHA 2 and 1. We have about currently about 26 or 27 patients who were referred to us for heart transplant, who we are just managing medically and who have a very reasonable quality of life. And this can be extended for years, certainly for months, but even for years. And so they don't need to have a transplant. So you have to determine that optimal medical management is reached, whether they have a good functional capacity, a good quality of life, to make sure all the rehab is done, and all non-transplant alternatives, both in terms of, say, TAVR and PCIs, under the guidance of ECMOs, patients with CABG, mitral valve replacements, all of these non-transplant alternatives have to be fully explored. This basically means we can also reduce the number of people who may require a heart transplant. So too late is somebody who's developed irreversible pulmonary hypertension. So what basically happens is any patient who has a left ventricular failure, the left atrial pressure goes up, which means the right ventricle has to do more work to push blood through the lungs. Eventually, the pressures in the lung become irreversible. And because a donor, by definition, is a normal person, the right ventricle there is usually subject to pressures of 25 or 30. And so you suddenly bring it into somebody, and you put it into someone who has a pulmonary pressure of 50 or 60, and it's irreversible. and then the right heart fails. And this is one of the commoner causes of failure of heart transplants is right ventricular dysfunction because of inability to control the pulmonary pressures post-operatively. Of course, other organs, cardiohepatic, cardiorenal, they have multi-organ transplants. We can come to that later. Severe sepsis and a bridge. Now, this is quite important because one of the newer paradigms that we deal with now is mechanical support. Chronic, long-term, permanent, or long-term bridge implantable devices are available. They are expensive. Their prices are coming down compared to before. Unfortunately, it's now the monopoly of one company, so the price is not going to come down in the near future. But we have a lot of temporary devices where the prices are coming down. Impeller is a temporary device, but again, that is expensive. But we have the ECMO machine, and we have a variety of pumps that are available to us now in the range of about 2 to 4 lakhs, for which you can support these patients. And we have supported patients for months together prior to a transplant. So this is also possible. And this is a newer paradigm, which basically means we have pushed the too late to transplant also further. So we have increased the too early to transplant and put patients away from the list. At the same time, we are taking in patients into the list who we would not have transplanted maybe 7 or 8 or 10 years ago, because of the availability of these newer support systems. I'll tell you that in a minute. So just a very quick way to say that when you as a general practitioner see a patient with heart failure in your clinic, you can have an aggressive approach or more likely a practical approach. And some are very conservative. They don't want to, because a lot of these drugs are double-edged weapons, because essentially what they do is a lot of them modify the renin-angiotensin system, which essentially tries to get the blood pressure down so that the left ventricle doesn't have to do much work. And this is the basis of virtually most of the therapy, because you cannot really improve the left ventricular function by improving muscle contractility. So you have to reduce the afterload. But when you keep doing that, there comes a point when the afterload goes down too much, and therefore there is a law of diminishing returns. So a lot of practitioners, both cardiologists and heart failure practitioners, tend to be a little bit more conservative in our population. There are risk scores. Again, these risk scores are not complicated risk scores. The Seattle Heart Failure Score can be done. It's a free app. Free calculator is available. It has about 27 different paradigms which you put into it. It gives you a very good, and if the patient has a prognosis which suggests greater than 80% survival at 1 year, they do not need to have transplantation. And this can be done by any general practitioner with a smartphone, with the most basic blood and the most basic investigations, like an echocardiogram or a 6-minute walk test. Very simple ones can go into the Seattle Heart Failure Score. The 6-minute walk test is again a very good score. If your patient is able to walk 6 minutes and covers more than 400 meters without desaturating, without getting any kinds of symptoms, again, their prognosis for the next 1 year is pretty good. It's a very simple test to do, and it's more than sufficient. The reason I'm putting all this up is, if we can, this also means that you have to diagnose heart failure earlier in patients, treat, risk stratify earlier, treat it medically better, make sure they get vaccinations so that they don't end up in ICUs with pneumonia, especially during the flu season. Or COVID vaccinations or flu vaccinations, all are very, very important. In fact, the flu vaccine has a mortality benefit equal to ACE inhibitors. So it's very important to remember that. When I started practicing here about 20 years ago, less than 5 to 10% would have a flu injection who had heart failure. Now, almost 90 to 95% of patients I see with heart failure have had vaccination. So that's a good news, and that's very, very important. Then, of course, determining the pulmonary pressures, improving them nutritionally. By nutritional, I mean not more food, because they cannot eat more food because they're unable to process it. So you actually have to give them smaller quantities, low carb diet, low calorie diet, control the diabetes, control the hypertension. All of this means that the patient can stay off the transplant list for longer. Now, this is an example of somebody who's had a cardiac arrest. This is all from our patients. So this is quite useful because now we can put them on the ECMO. We can support the heart when it's not working after cardiac arrest. If you're going to transit them to transplant or to recovery, we can still rehabilitate them. They're awake, they're extubated, and you can see that this patient is doing chest video. This is one of the most important advances that we have in managing critically ill patients in the ICU, which is waking them up and using the ECMO for physical rehabilitation. So again, and this is a patient who's again being supported by a ECMO machine, but is awake, able to read letters, gives them a higher quality of life while they wait for a transplant. They also can consent to a transplant in case when they came in, they were acutely ill. There are a variety of different things, from very simple things like mobilizing them on the bed using very sophisticated beds. And the one on the right is a patient who's had a massive myocardial infarction, who's undergone CABG and is being rehabilitated. So normally such a patient would have had a transplant in the years past. So exploring alternatives, as I told you. So this is again a patient who came in with very sick heart, extreme heart failure, supported, was shown to have aortic regurgitation at a high risk valve replacement. These are the more commoner kind of patients that you might see who require, who would have in the past either died or would have developed severe heart failure and would have ended up on a transplant list. But because we are able to reduce the inotropes early on by putting them onto VA ECMO earlier on, we are able to recover more of these hearts which had otherwise gone into transplants. So in the adults, the VA ECMO is by taking blood from the internal jugular and from the right atrium through the internal jugular and the femoral vein and giving it into the femoral artery while protecting the distal limb because you have a very large cannula. This is the easiest form of VA ECMO that can be done in the adult at the bedside. In children, we have to do it from taking the blood from the right atrium through the internal jugular and giving it back into the carotid because their femorals are very small. These are patients who, if you treat everything earlier, the chance of progressing to fulminant heart failure or to chronic heart failure is reduced. So I just want to put up the slide to show that if you can support these patients, you can improve them metabolically very quickly, which you cannot do with inotropes. So here, the lactates have come down quite significantly, as you see, from 16 to 4. This is again a patient post-transplant, post cardiac arrest. So this is a patient who had a myocardial infarction, treated with a balloon pump, and that was not sufficient, then escalated to a peripheral VA ECMO. Some of these patients will not improve their heart, and they will need to be transplanted, and they will go on a bridge to heart transplant. This is an example of somebody with a severe right ventricular dysfunction. The LV is relatively preserved. This is from a myocardial infarction. So in the past, somebody like this, even if they manage to get medically treated in the ICU, what would happen is they would end up with chronic heart failure and eventually require a transplant. But now what we can do is we can stabilize them, prevent that repeated arrests, and make them metabolically better. I show the lactate come down, take them to a cath lab, and they can. So here you can see that they can have an angiogram while they are on the ECMO. So this will help us do a PCI, which means that we can protect larger areas of the myocardium. And when you can protect larger areas of the myocardium, you don't have to end up losing more myocardium and then end up with a transplant. So this patient actually had a CABG, then de-escalated down to an RVAD, and then was taken off the thing. Occasionally, and I'm almost about to finish, we do have patients with more than one organ dysfunction. This is somebody who had cardiac cirrhosis from Epstein's anomaly. And there are patients who have irreversible pulmonary hypertension, or those who have very bad lungs in whom the heart also begins to fail because of cor pulmonale. They will require multi-organ along with heart, as in this case, heart, lung, and heart, liver. And the reason, so why donate organs? So I've taken pictures from our own patients. So this young boy who's 11 years post-transplant, he came to us when he was a 12th standard student. He is now a certified chartered accountant working with a corporate in the Middle East and doing extremely well. We have another patient who had a heart liver transplant, is now 8 years post heart liver transplant. One of the big concerns is, will I be able to get married? Will I be able to have a normal family? So this picture is just to show that all that is possible. And this is a patient who had a cardiomyopathy, severe dysfunction, who was bedridden, and now 12 years post heart transplant, he's riding horses. And on the right, you can see about 2.4 years post heart and lung transplant is somebody who had Eisenmenger's syndrome and was again bedbound, but she's now skydiving. And this is just to tell you, this is where we try to put the organs to good use and help people have a normal and productive life. Thanks once again for the opportunity. Thank you very much.
Thank you, Dr. Paul, for giving a very elaborate coverage of the problem to understand. And I'm sure still we have lots to be done for making the organs available, for reaching the person on time. That is the most important message we could understand from it, because availability of organ at the right time for the right patient is the most important mantra for the success of the transplant services, especially as far as heart is concerned. And it's very heartening to see people getting back to their normalcy after a successful transplant. I wish the organ transplant from the cardiac perspective takes it more deeper to the medical fraternity. So appropriate efforts are taken at the right time so that people reaches or people gets the benefit of your type of expert services so that the society around that individual benefits of it. Thank you very much, sir.
Thank you.
Dr. Edwin, would you like to give comments on what Dr. Paul was speaking before you start your talk?
Yeah, I'm really proud of Paul because Paul was 1 year junior to me in college, and I'm really happy and proud to know the great work that he and his team members are doing. And heart transplant is something that's relatively new to this country. I think the cardiologists actually have to register the ideal patients for a heart transplant. I think that's not really happening. For example, as nephrologists, we have registries, we have a kind of a waiting list, etc., and we identify patients for transplant. However, I don't think that's happening as robust as what Paul and his team would like to do. So if that is done, then Paul and team would have more work to do. Is that right, Paul?
Yes, absolutely right. I mean, that's what I was trying to point out, that it's either they sent in too early or they sent in too late. But if you had a registry and you could follow them through these risk scores, then you could more appropriately tell patients, and you got to counsel them, because a kidney transplant is now kind of culturally very acceptable for patients. But even now, a heart transplant is a very shocking thing, and patients really don't want it. And the cardiologists feel the moment they mention that, they lose the patient. So they really don't want to bring it up.
At this point, I want to say that the heart transplant, the transplant team at Johns Hopkins, Robert Montgomery, he underwent a cardiac transplant, and 2 weeks later, he got into the operating room and did a liver transplant on another patient. So that's a huge thing that that could ever happen. Just imagine somebody having a heart transplant, and 2 weeks later, he himself he's a huge transplant surgeon, Robert Montgomery. And that was came on Twitter, and it's a really great news.
Thank you, Dr. Edwin, for bringing in such a more important viewpoint and sharing the very, very impressive feat by a heart transplanted surgeon to do a liver transplant. Kanjimati ma'am, would you like to share your views, ma'am, on the status of cardiac transplant, especially in Tamil Nadu, and what is your viewpoint for the upcoming years for the cardiac transplant as such?
Tamil Nadu is doing the highest amount of heart and lung transplants when compared to any other state in India. And we are the only people who go to other states. So we do a lot of this coordination work with Delhi and Noto, thanks to our heart and lung teams, I should say. So they go out of state to get organs. So that is what I was talking about, the air ambulance services. Paul Ramesh knows about it. And to get chartered flights, to arrange for the green corridor, all that takes a lot of effort from our side also. But I would like to make a point that the post-transplant outcomes are definitely better here, as well as one other thing is the utilization, organ utilization, especially heart and lung. I found that it is a bit more than when compared to international standards. Normally, international standards, the lung utilization is just around 20% or so. I think Paul Ramesh is a better person to tell regarding that. And I think heart transplant should be anywhere around 30%. Am I right?
Yeah, that's absolutely right. It's around 25% to 30% hearts and around 15 to 20% of lungs are usable.
But in Tamil Nadu, what I found out in the last 2 years is it is more than 20, it is almost 28% or so lung utilization, and heart utilization is somewhere in 38 or 40%. So ours is a very good statistics in Tamil Nadu. So, but thanks to our heart and lung team, definitely. They not only take organs from our state, but they go to any state to take organs. So thanks to them.
Thank you.
Thank you, ma'am. Thank you, Dr. Paul, for taking this. And once again, I'm sure India will be making a role model work on the cardiac transplant. We wish you all the very best for your upcoming projects and efforts on the cardiac transplant.
Thank you.
With your permission, we move on to the next talk. Again, a good friend, senior Professor Edwin Fernando, who was the very fond teacher for all his postgraduates who are excelling in the field of nephrology across the country. And today, I'm proud to share Stanley Medical College Department stands in the top single-digit choice for the students who wish to take DM nephrology as a profession. And I'm sure the research work, the commitment towards the society, and the amount of transplant discipline and the dialysis discipline and the interventional nephrology discipline which has been inculcated to the next generation will sure map Tamil Nadu as one of the most academic department of nephrology ever existed in the field of nephrology. Ladies and gentlemen, on behalf of the President of the IMA Tamil Nadu South and the Organ Donation Committee, I take immense pleasure in welcoming Dr. Edwin Fernando to share his viewpoints and thoughts on kidney transplant especially. Over to you, sir.
Thank you, Dr. Kanagavel, for the very magnanimous introduction. And kidney transplantation and organ donation has been one of the lead organs that has been transplanted that have happened all over the world and more so in India. The first live related transplant was done way back in 1971 at the CMC Vellore. And the nephrologist, Dr. K.V. Johnny, is still alive and a very healthy man working at Kochi. And the surgeon, Dr. Mohan Rao, is in Australia, also doing well. So what is organ donation? Donating healthy organs from one person to a patient who's in need of that organ. So when do we transplant an organ? Live donation has been with us for quite some time as far as kidney is concerned. Of course, we are talking about disease donor where we have circulatory death and the brainstem death. These are the donors that we have, and what are the organs that can be donated? A live person can donate blood, bone marrow, one kidney, portion of a liver. While after circulatory death, one can look at the corneas, the heart valve, skin, bones, tendons, cartilage, veins, and arteries. And the corneal donation can be done even after death. So this is a well-established fact. Many of our members may not really understand what brainstem death is. A lot of times we get calls for to retrieve organs in patients who have already died. So you have this small area, the brainstem, the stage at which all functions of the brainstem have permanently and irreversibly ceased. So this is brainstem death. So normally the brainstem takes part in breathing, digestion, being awake and alert, BP, heart rate. So many things are controlled. And the common causes of brain death being trauma, most common thing, road traffic accident, intracerebral bleeds, large ischemic infarcts, or tumor in the brain. And India leads the world in road traffic accident statistics, not something to be really proud of. And it'll become the 5th biggest killer by 2030. And we have a huge number of patients who meet with RTAs. Now, essentially, patients who are brain dead are in an intensive care unit, in a neurosurgical or a trauma unit or ventilators. They have extensive supports. And brain stem death certification is certified by a panel of doctors, and tests are conducted at an interval of 6 hours. So the parent unit identifies that a patient could be probably brain dead and then calls in the neurologist, the neurosurgeons. Then they do a lot of brain death certification maneuvers. So public and other colleagues should not feel that somebody is dead and somebody's brain dead and immediately organs are harvested. So there is a process that is very meticulously followed because all these are medical legal cases and one has to be very careful while certifying the death and also to follow all the protocols that are followed. So this is the disease donor maintenance unit that is very peculiar at Stanley Medical College. Because in a trauma unit where there are about 10 patients with head injuries and other sorts of neurosurgical cases, identify somebody with brain death. Now this brain dead person, once the family consents to donate, now these organs have to be retrieved at the best possible way so that it is put to use, good use to all the recipients. So we have to take special care of this particular person who's deceased donor. So in that particular unit where there are 10 other patients, this patient will be less cared for because the nurses and the others would probably look at saving the other ones. So this patient is deceased donor shifted to this cadaver maintenance unit where a special team takes care of these patients, make sure the brain death certification is done well, make sure all the organs are in optimum working position, and the organs are put to best use. So these are the various organs that can be taken the brain dead individual. Now, we go through a lot of tests. So the eyes can be donated, the lungs can be donated, the heart, the liver, pancreas, kidney, all these could be donated. So the need for organs is increasing every day. The gap between need and availability is growing wide, and many people die while waiting for an organ. So you look at this chart, you see that patients awaiting transplant, the numbers are increasing while the transplanted recipients are still, the curve is much low. All of you should know this gentleman, Dr. Ashokan. He and his wife practice at Tirukalaikundram near Chengalpattu. And he was the person who actually initiated this process, though we did our first organ transplant, disease donor transplant way back in 1996. After that, there was a lull. So Dr. Ashokan's son met with a road traffic accident, and he and his wife, Dr. Pushpanjali, took a very brave decision to donate their son's organs. And Dr. Ashokan did not stop there. He did not stop with his son. He regularly goes to other colleges and other institutions, talks about organ donation, pledging organs, etc. So we had him in our hospital for the World Kidney Day. So there are some myths. Doctors work less to save you if you're an organ donor. No, doctors work equally hard to save every life. Everybody in the trauma ward, the team looks to save people. We are talking about the people whom we really cannot save. And people also have an idea that the doctor is withdrawing treatment. No, the doctor is not withdrawing treatment and allowing somebody to die, but ceasing to do something useless to someone who's already dead. Now, if you disconnect this patient's ventilator, is going to die. So this is the time when we talk about brain death and we go through the processes. And once the brain death certification is done by the team of surgeons, we report it to TransStan, where the TransStan team works on the waiting list. It's a very transparent waiting list. Nobody can bypass the list unless there is an emergency. For a kidney transplant, we have a beautifully maintained waiting list, which the patient and the hospitals themselves can log in and see their positions. And once TransStan allocates the organs, it is only TransStan that allocates the organs. No hospital can retrieve organs without the permission of TransStan. So TransStan is in complete control. That means the government is in complete control, whether it be a government hospital or a private hospital. And the allocation of organs is done only by TransStan. And there is an app called the VDL app through which the allocation process goes on. And once the allocation is done, and initially the family has to accept, we have grief counselors and transplant coordinators who speak to the family and then take their consent. Is actually we have to salute the family of these donors in their moment of grief and having lost a loved one. It needs a lot of magnanimity in coming forward to donate. So this is a thoracoabdominal exposure where from the xiphoid to the pubic symphysis an incision is made. Of course, the heart and the lung teams take a lot of care in measuring the chest wall, and they actually take a lot of care to make sure that the recipient gets the right organ. Once the heart and the lungs are retrieved, then the liver is retrieved, and the kidneys actually are the ones that are retrieved at the end. You can find both the kidneys en masse lifted out, and then you can see both the kidneys. This is one of our patients who underwent cadaver transplant on Friday at Stanley Medical College.
Edwin sir, sorry to trouble you. Edwin sir, your slide is not moving. We're not
Sir,
able to see
your slides are
moving,
not.
sir. Yes, sir. Yes, sir.
Now, can you see this?
No,
one?
sir. Please unshare and reshare the PowerPoint, sir.
Oh, but it is showing that it's screening.
No, sir. We are able to see the first slide.
Oh, not at all moving, is it?
I sent a private message, in fact, sir.
Oh,
Twice.
oh.
No problem.
I'll just come back.
Yes, sir.
Can you see the slide now?
Sir, make it full screen, sir.
Yeah. Can you see it now?
We are able to see the slide, sir. It is set in the regular mode.
It is on.
Sir, try moving the slide, sir. If it is moving, we are fine too.
I'm moving it now.
No, sir. We are unable to see your slides moving, sir.
It's moving for me.
Sir, I wish you unshare this and start sharing your desktop, sir.
Okay.
Yes, sir. Now you open the PPT, sir.
See it now? Can you see my slides now?
Yes, sir. Yes, sir. Yes, sir. Now things are moving good, sir, and you are good to go, sir. Please continue from the slide where you left, sir.
I'm so sorry. I'm so sorry. I
no
wish you
problem,
had told
sir.
me
You were
earlier.
sending messages probably as you are talking, you could not see.
Yeah, I'm so sorry. So this is Dr. Ashokan whom I was talking about.
Yes, sir. Yes, sir. Yes, sir.
Right. So what it is important to recognize for our members and also for the public that we are not withdrawing treatment and allowing somebody to die, but ceasing to do something useless to someone who's already dead. So this is the once the organ allocation is done and Transstan gives us the clearance to go ahead. This is a huge incision made from the xiphoid up to the pubic symphysis. And initially the heart and the lungs are retrieved, then the liver, then the kidneys. So here you can see the kidneys retrieved en masse. And this is one of our patients whose disease donor was done at Stanley. And you know, one of the kidneys is getting allocated to some other center. So it may be from Stanley Medical College, Madras Medical College may take, or it may get allocated to the one of the private hospitals. So we have to make sure that we transport the organ in a very sterile manner and hand over the organ well. And in the center, which we call this the local kidney sharing, where the surgeons go through the kidney and then do bench dissection. We then perfuse the kidney with certain solutions are there. And then this is the artery, and you can see this is the artery, this is the renal vein, and you can see the ureter here. So this is the incision for kidney transplant surgery, otherwise called the inverted hockey stick incision. And we make anastomosis. The urologist makes anastomosis between the graft artery and the internal iliac or the external iliac artery. And this is the external iliac vein and the renal vein, and the ureter is anastomosed to the bladder. So this has to be done as quickly as possible. Shorter the ischemia time, better is the outcome for the patient. And once the kidney is transplanted and the clamps are released, you can see the kidney fully perfused. In a deceased donor transplant, it may take a little longer time for the urine to establish because there'll be some ischemia time compared to a live related donation. This is our post-transplant ward at Stanley, where there is a reverse barrier nursing. And we have very dedicated nursing staff who have been working in the department for the past 15, 20 years. And it is the one-to-one care that these patients are given that contributes a lot to the success of the program. Again, certain myths: organ donation will disfigure the body. Organ retrieval is a very neat surgical procedure. The body is treated with care and respect. There will not be any disfigurement of the body. In fact, a couple of years back, we even did a bilateral hand transplant at Stanley, where both the upper limbs were done. This is the deceased donor at Stanley this Friday, just 2 days back. Our Dean, Dr. Balaji, is paying his last respects and thanking the family members, and we provide free hearse services for this deceased donor to reach his home so that the family can perform their rites. So is there any money if I donate? No, nothing. Even in a private hospital, the billing will stop from the time of consent. No religion is against organ donation. All religions endorse organ donation as the most supreme form of gift. Am I too old to donate organs? Any healthy person can donate organs. Of course, the final decision to retrieve the organs is vested with the organ procuring doctors or the transplant centers. This I already alluded to. The rich and famous will jump the waiting list to get organs. A transparent system is maintained by the government, TransStan, and the organs go according to the waiting list only. Can people recover from brain death? No. That is why brain death and coma are not the same. Somebody can be comatose and still can come back. Somebody can have a hyponatremia and coma or hypoglycemia and coma. They can all come back. That is why first certification is done. Then 6 hours later, a second certification is done by a different team just to make sure that no mistakes happen. Or organs sold for a price, no organ shall be brought or sold. The Transplantation of Human Organs 1994 prevents any commercial dealings. And this is a survey regarding the knowledge and attitude regarding organ donation among medical and non-medical students. Of course, it is very obvious that the medical students had a better knowledge and awareness about organ donation. So this is the TransStan website that I make sure that all of you go through this website. And this is the video lab that I was talking about. On Organ Donors Day, we pay tribute to the organ donors. We call their families and pay homage to them and appreciate them for their the gesture. So these are all organ donor families who had given their donated the organs of their loved ones at a time of great grief. Salute to these families. Again, this is the Tamil Nadu website. This is TransStan. It was formed in 2014. It works towards assisting all persons with health issues, including organ and tissue failure related health problems, to overcome their ailments. And the disease donor renal transplantation program was one of the programs that took off in this country. Tamil Nadu was the first. We had a lot of publications in international journals about how Tamil Nadu turned the tide on the transplant program. And there's a donor card. I think all of you should pledge your organs, the organ donation pledge form. And these are the Stanley team was awarded for best performance. And this is our department at Stanley, our data 928 transplants, out of it 148 is live. And these 2 years, we did not have any cadaver transplant, because of the pandemic. 148 transplants. This year we have done 5. We had done a peak of about 18. And this is Organ Donation Awareness Day at Stanley. And it's important that society also should play a crucial role in creating awareness about organ donation. And most important thing is to dispel the public concerns. and organ donation can give a new twist to tragedy. Remember, organs wasted are lives lost. So this is Australian Nephrology Society. Don't take your organs to heaven. Heaven knows we need them here. We make a living by what we get, but we make a life by what we give. So this is from the TransStan dashboard. So far, 10,003 organs have been donated by the deceased donors. So of course, the kidneys are large because we have 2 kidneys, so it goes to 2 individuals. So 2,986. This is the heart that Paul and Gandhimati madam were alluding to. The lung also a large number. Liver, of course, Dr. Leela told you about the numbers. So I'm reminded of the words of John Maxwell. When I die, I cannot take with me what I have, but I can live in others by what I give. So with this, I stop my presentation. Thank you very much for the opportunity. I'll be happy to answer some questions.
Thank you, Professor Edwin, for giving a very vital viewpoints, especially you touched upon the areas where the other speakers did not do, when to certify, how to declare, and the process of how it happens. And it was touching to see the dean himself coming to play the last rites of a donor. It is ultimately a very distressful situation for a potential donor who has had an untimely death or loss in the family. And I think I would say I will place there next to God for making a decision at such a stressful period to willingly donate. And I'm sure the recipients and the potential future recipients should be ever thankful. And I wish everyone mentally makes their mind to donate the ultimate. Giving the life to a life is the right message I would like to share here. And I'm sure what little possible we are leaving this world should be of the benefit of the society. And I thank Professor Edwin sir for staying with this on a Sunday, such a late night.
Thank you,
and
my pleasure.
Who was willingly accepted our invitation. And this is the second time he's contributing to the IMA within this short span of 2-3 months. And I'm sure Stanley Medical College and your leadership will ascend to a humongous academic contributor to this part of the world, as well as to the entire nation, globe. I'm sure your publications have already made humongous impact, and I wish you to serve many long years for the cause of the humanity. And on behalf of the IMA president and the IMA members, we thank once again for sparing your valuable time.
Thank you.
And
it's a
we
pleasure.
look forward for more active interactions, sir. Thank you very much.
The other thing I wanted to mention is we don't reveal the recipient's name and to the donors' families. So
okay.
Even in the press, you will see so and so donated. The donor's name would come out, but it would say so and so recipient will never be mentioned.
Will they be permitted to
that these
visit?
Organs were donated. That's it. So we make sure that the recipient's families and the donor's family don't meet. They don't get to know each other. So just to maintain secrecy, and also sometime emotionally they can go to the recipient's family and start demanding some favors. So all this has not happened because we keep it strictly under wraps.
This is a very important piece of information, sir. I'm sure this is one thing all of us should be aware. As a medical fraternity, we can help them to get the transplant done. And maintenance of secrecy and the confidentiality is one important message Professor Edwin has brought in. And I'm sure, sir, all of us from IMA also will continue to maintain the trust and secrecy what you have been doing. Very important information, sir. Thank you very much, sir. Good night, sir. Thanks for joining today. Dr. Jayaraman, sir, over to you.
Yes, sir. Very good evening. Welcome. This is the last speaker. May I introduce Dr. Soumitra Sinharai. Soumitra Sinharai is MD DTCD FRCP. He underwent a special training in Toronto, the Center of Excellence in Lung Transplantation. So he underwent training program in Toronto. Dr. Soumitra Sinha is currently a consultant, senior consultant and transplant pulmonologist, interventional pulmonologist working in MGM Healthcare. So, you know well the history of lung transplantation for the past 10 years in India and mainly in Chennai, happening so much of cases. After the COVID, the lot of lung transplantation, the awareness among the lung. After COVID, the lung awareness, pneumonia, lung failure, ECMO, the lung transplantation awareness is very high after the COVID. So, Soumitra Sinha is a very great experience in MGM Healthcare, and Dr. K.R. Balakrishnan, lung transplant surgeon. Commonly, they are doing a lot of lung transplant program. So, with this few introduction, may I welcome Dr. Soumitra Sinha to present this lung transplantation overview and Indian perspective. Over to Dr. Soumitra Sinha.
Good evening, sir. And thanks a lot for giving me this opportunity to talk to all of you, the stalwarts of IMA Chennai. As because the time is really, really late, I would try to be as short as possible, only focus on the most important things. So the next slide, please. Okay, so this is the Toronto General Hospital where the first lung transplant has started somewhere around 1960s. They have started doing the single lung transplant and then followed by the double lung transplant. However, in India, perhaps we are fantastic in all the other kind of transplant, the liver, the heart, the kidneys. Obviously, we are at par with the world. However, we started lungs somewhat late. We started somewhere around 85 onwards, only the transplant. So this is the hospital where the first lung transplant happened. Set the next one, please. Okay, so in this hospital only the insulin was first discovered, and this is their second gift perhaps to the world other than the insulin. Next one, sir. So I will start with a quiz. 32 years nurse who was working in Toronto General Hospital. She is a known CF, had bilateral lung infection, septic shock. She was doing fine before having this sudden acute infections, and she was found to have Pseudomonas and MRSA. She was on transplant list, but we did not envisage that she will be having suddenly such a bad scenario. She is now in ICU and on ventilator, on extents on vasopressors, and on all kinds of antibiotics, nebulized antibiotic, antifungal, on ECMO. This is moribund, no improvement. What next? The normal usual scenarios is we continue to treat sepsis and try to support, etc. But the surgeons there was a very valiant surgeon, I would say. He has taken the easiest solution. Where there is infection, take out the source of infection. So they have taken the patient to the OT. Both lungs were taken out. Patient was back again to ICU without lung, without ventilator, on ECMO. And there was a red alert gone out for all over the country for a transplant possible lung. And about 18-19 days she was on like that, and then after a suitable lung was available for her, transplant done, and the patient walked out of the hospital after about a month or so from the hospital. So that's the day we are perhaps striving towards, that we will be having that kind of expertise and that kind of availability of organs in our country for lungs also. The next one, please, sir. So this is the history. As we said, it started from 1963. Dr. Joel Cooper was the first person. The next one, sir. The double lung transplant happened at around 1988. In India, the first heart lung was done by Dr. K.M. Cherian in Chennai in 1995. Chennai is always the forefront of all the transplant scenarios and bypass surgeries scenario. So Dr. Cherian was the first person who has done the heart lung. The first lung was done in global in 2008. And since then, after we started doing a few steps, and now we are strong enough to be not in the infancy, but now we are perhaps in the adolescence to the adult periodhood, I would say. The next one, sir, please. So these are the global scenarios, how many lung transplant was done. You can see over the period of time, the double lung transplant is happening more than the single lung because there are many benefits of a double lung, and the longevity of a double lung transplant is much more. So as you see, there is more and more double lung only when there is no infection and the patient is in the borderline high age of say 75, 76, and not in a case of an infective focus kind of thing, only with an ILD perhaps, we usually do a single lung in that kind of cases. So next one. These are the commonest causes. Though COPD was somewhat commonest at the towards the 20 years before, also perhaps slowly the ILD is taking it over. Now I would say ILD is just equal or maybe slightly more indicated, the commonest indication being ILD than COPD. Others are CF and FIC, alpha-1 antitrypsin deficiency, idiopathic pulmonary artery hypertension, and all the other connective tissue disease, sarcoidosis, etc., etc. LAM is another very important indication for transplant. Next, sir, please. So the survival after transplant, the median survival means a person who has survived the first year after the transplant, how many years they survive. This is the 2019 data. ISHLT has stopped publishing their data after that. So you can see the maximum number of survival, the upper one, the are from the CF, which is about 13 years, and idiopathic pulmonary artery hypertension, which is about the same of 12 years. The next group of people surviving are the previous one, sir, please. The previous one. The next group of people who are surviving it is around the previous slide, sir, please. The alpha-1 antitrypsin deficiency, and the worst surviving people are COPD and ILD, which is about 7.5 to 8.5 years. And the mean survival after the first year of survival is for them. But this is the data of 2019. Perhaps in another 4 or 5 years, we could have progressed slightly better. So I would say now the ILDs and COPDs perhaps live about 10 years kind of thing, and alpha-1 antitrypsin, CF, and idiopathic pulmonary hypertension, some are about 13 to 15 years is the median survival. Next one, please, sir. So the commonest conditions, as I have shown you, COPD, IPF, CF, alpha-1 antitrypsin deficiency, and all other fibrotic lung diseases. Bilateral is preferred. Single lung transplant is only done in emphysema and in the extreme ages with ILD or IPF kind of decisions. Heart lung transplant were done only in a rare conditions where there is an end-stage cardiac and pulmonary disease together, like Eisenmenger syndrome with PPH, or a significant, there is a left ventricular dysfunction also along with the lung disease. In that kind of scenarios, only a heart lung transplant is being done. Next one, sir, please. The end-stage lung diseases, the commonest other conditions are COPD, IPF, chronic HP, bronchiectasis, etc., etc. The next one, sir, please. They will be having type 1 and maybe type 2 respiratory failure. The definition for the progressive fibrosis, I'm focusing slightly more here on the ILDs, the fibrotic lung diseases. So the progressive fibrotic lung disease is the commonest indication as now for the transplant. So what is the progressive lung disease? Not only the IPF, as you can see in this picture, not only the IPF, the other conditions like CTD-ILD and the conditions similar to CTD-ILD, are fibrotic NSAIP, chronic fibrotic HP, sarcoidosis, perhaps a part of it, and other ILDs also comes into this progressive fibrotic lung diseases. Next one, sir, please. The risk factors for progressive ILDs, these are the, if there is an UIP pattern in the CT scan, or if there is a extensive traction bronchiectasis, rapid progression of the disease, no disease regression or stabilization with the therapy, as you are seeing, presence of a telomere, short telomere disease, older age group, these are probably the risk factor. We should look for those things in an ILD patient, and then we know, and we should start discussing with their relatives that this patient will be going downhill much more faster, and these are the risk factors for them for a progressive ILD. In connective tissue disease, the rheumatoid arthritis with a smoking disease, smoking status is having a higher risk, and older age in systemic sclerosis, associated GERD in systemic sclerosis are again a risk factor for a quicker progression. Next one, sir, please. So these are the different fibrotic lung disease and which will go beyond a stable disease and may require a transplant. Next one, sir. So I will say again a few things about IPF, which is the commonest again the disease. The rate of decline in the vital capacity is about 150 to 200 ml per year, and the DLCO decline has a prognostic significance less than 35% is having a worse prognosis. Potential risk factor to develop IPF, though it is an idiopathic thing, that perhaps also cigarette smoking, some environmental exposure to the metals and fumes, microbial agents, perhaps with EBV or hepatitis C. GERD is a very common and very important comorbid conditions with IPF. IPF gets worsened with IPF with GERD, and if the GERD is severe, the post-transplant lung also will be affected. So that is a very important focus for us to evaluate before transplant. How is the GERD scenario? The familial diseases and the genetic factors are also important for an IPF to happen. Next one, sir, please. In this slide, I just wanted to show that IPF has a very, very relentless progression. Whatever the drug we give, we have very little drugs. Whatever the drug we give, the 20 to 30% of the patient will be still alive after 5 years, and the median survival is about 3 years. And as you can see in this slide, the other diseases, I have just compared IPF with the other cancers, and as you can see, only 2 cancers have got lower survival than IPF. Those are lung and pancreas. All other cancers are having better survival than IPF. That is an important focus I think we should take back home. Next, sir. The progression in CTD-ILD are somewhat similar. There will be the commonest 2 diseases are the rheumatoid arthritis and systemic sclerosis. Next one, sir. This is how we manage the progressive idiopathic fibrosis. Most of the cases of connective tissue disease, we start with the immunomodulator. The commonest is the steroids, except in systemic sclerosis related ILD, and then the other immunomodulators like MMF and cyclophosphamide, rituximab, or abitaliprotein, etc. And then finally antifibrotic drugs, and then finally the non-pharmacological treatment with oxygen, psychological support, smoking cessation, etc. And then when the disease progression is still relentless, you will consider management with the transplant. Next, sir, please. So the indication for transplant is based on this landmark studies, which was done in 2014, which came in 2014, and also it has been updated on 2018. Also that on this basis, this our diagnosis and who are the people who need to be selected for transplant happens. Next one, sir, please. So next one, sir. I will just talk about ILD. When is the time for listing? There are 2 things. One is called time for referral and time for listing. At least let's talk about the time for listing, when a person needs to be listed for transplant. And after listing in Indian scenarios, perhaps we need about 2 to 3 months or maybe 3 to 4 months of time for the person to get the lungs. So a decline in the vital capacity of more than 10% during the last 6 months, and a decline in the DLCO or a desaturation to less than 88 and pulmonary hypertension are the common indications for the ILD to be listed for transplant. Next one, sir, the COPD. In the COPD also, the next one, sir, the time of listing is important, where the board index, that is the index for longevity for COPD, that if the board index is more than 7 or FEV1 is very poor of less than 15%, more and more number of exacerbations, pulmonary hypertension, these are the some indications for time for listing for COPD. Next one, sir, please. So the contraindication, I will just go through this once. And the malignancy in the last 2 years is an absolute contraindication. Other absolute contraindications are if there is some advanced dysfunction of another major organ system, or if there is an atherosclerotic disease of the heart, which is not amenable to CABG also, And if there is acute sepsis, MI, and liver failure, acute condition, acute medical instability, or an uncorrected bleeding diathesis, evidence of active TB, significant gestual or spinal deformity, BMI more than 35 is also an absolute no-no. We should target towards a BMI of less than 30 is the target. Between 30 to 35, it is perhaps we should have a goal towards less than 30, and we will try everything in our power to reduce the weight for the patient. Other than that, the psychogenic and psychiatric conditions are also important contraindications. Next one, sir. The relative contraindications, perhaps more than age of 75 or 65 with a low physiological reserve and a BMI between 30 to 35, severe malnutrition, and patient on an ECLS with no way out, or an ECMO or a mechanical ventilation with no way out, having other major organ dysfunctions, are perhaps a contraindication for a transplant. Next one, sir, please. This I will pass on. Go, sir, next, please. Go. Next one. Next, please. Next. This is how the lung was taken into the theater. Next one, please, sir. The marginal donor. I will just talk about things as the donor conditions in India is good, but in the lung cases, most of the cases of, as the patients are on ventilator, perhaps more than 3-4 days on ventilator, the lung gets infected, and the PF ratio becomes altered. So there is slowly a demand is coming because there are a lot of people waiting in the wait list. So to extend the disease, our strict donation criteria to somewhat marginal donors. So the age and smoking status are slightly being considered now, increasing the cold ischemic time in the DCD. Somewhere about we have got a transplant done from the heart and lung was taken from Chandigarh to Chennai. That was unheard of basically in Indian scenarios, I would say. Dr. Bala has done a remarkable feat in doing this. There were 2 plane transfers from Chandigarh to Delhi, Delhi to Chennai over the commercial jet, and the patient was transferred, the heart was transferred to a person and the lung was to a lady, and the lady was actually from Chandigarh also. And both these patient recipients, both the heart and lung recipients are doing fantastic. So even with an 8 hours of ischemic time period, the heart has and the lung both has survived well, and the patients are doing well. So this is how we are thinking of now doing extension by DCD, donation after cardiac death. And sir, next one, please. This ex vivo perfusion is again another reconditioning of the lung, which we are getting if there are infections or if the PF ratio is poor. We try to get these infections better. We try to get the lung inflations manipulated by that through a bypass machine and other perfusionists, and the pressure changes and the PF ratios we will monitor. We will see the pulmonary vascular resistance. Somewhere about 6 to 10 hours of ex vivo perfusion makes the lungs better. There are many papers now has been published showing that ex vivo perfusion, after ex vivo perfusion, lungs are really doing better. Next, sir, please. This is how the ex vivo perfusion is being done. Next one, sir, please. After 6 to 10 hours, it looks like this. Next, sir, please. The surgery is this kind of surgery, clamshell incision is being done for the double lung transplant. Single lung transplant will be one-sided. Next one, please, sir. Next, please. Complications are important. The early complications are ischemic changes, infections, and the last one is the acute rejections, infections, and the technique PGD. These are the most important early complication. More than 3 months or 6 months, more than a year, the infections and the chronic rejections are the common complications. Next one, please, sir. If you take next one, sir. If you take that freedom from the chronic rejection is about the median age is about 7 years. After 7 years, almost 50% of the people will be having some kind of a BOS. They need not to have oxygen requirement, but they might be having some impairment of the lung function. With a long-term adult lung transplant cumulative morbidity you can see the hypertension, renal dysfunction, hyperlipidemia, diabetes, and this chronic rejection are the commonest thing. Though the renal dysfunction is common, but the needing dialysis is perhaps only about 3% of the people is happening. Next one, please, sir. Causes of death, commonest is rejection and the chronic rejection and acute rejection. Then the malignancies and the infections come into picture. Next one, sir. So at the early time between the first 30 days to 1 year period, the infections and the graft failure is the commonest cause of death, whereas after 1 year, those are coming down and more of chronic rejections and infection remains the forefront for the incidence of leading cause of death. Next, please. So next one, please, sir. Next one, sir. So the situation in India, and perhaps in our hospital, Dr. Bala sir, with his immense acumen and his activities, he has managed to do 127 double lung transplants since he has started doing the transplant. Out of that, about 27 is a heart lung transplant and 19 post-COVID pneumonia transplant. The first post-COVID pneumonia affected lung transplant in the Asia region has happened first in this hospital only. So in spite of all these success stories, the problem areas still are many. First is, again, as I said, the donor availability. More of the lung, the liver and kidneys are, and the hearts are perhaps better. Donor availability for lung is still somewhat difficult. The social, religious taboo, and the hospitals perhaps are not always geared for organ transplant drive. Referral to the patients to the transplant centers are also somewhat late. Maybe they are coming slightly late conditions. We need to consider referring earlier. The infections, graft dehiscence, the ventilator-associated pneumonias, all these are major problem areas we have to overcome slowly, both in the recipient and in the donor. The logistic issue, again, this is a unique for India, obviously, because we do not have that much of money for hiring a private jet to go to a center where the donation is happening. We have to depend only on commercial flights and commercial ambulances, and this is actually never has happened in Western countries. So that is again India related specific logistical issues. Cost and infrastructures are important. Just to give one example, the organ donation rate in India is fine, somewhere about 0.52 per million population, but in comparison to US, that's very poor, somewhere about 36 donors per million in US. This is in 2019. So with this kind of situation, we are working. But in Tamil Nadu, the good thing is the government of Tamil Nadu has a fantastic hand-holding scenario for all the organ transplant. This is the only state, perhaps I know, in India who gives almost every amount of transplant for the poor patients. The Tamil Nadu government scheme is available for all the heart and lung transplant patients. So that's a fantastic scheme which can be emulated by all the other states of country. Again, the donations are also much better in India, better in Tamil Nadu. So these are the positive things, and we have to take things further in front here. I think I will stop here now, sir. There are many things to talk, but perhaps let me stop here. And I hope and pray that our lung transplantation will be as in the same group as in the world currently in a few years time down the time. Thank you.
Thank you very much, Rai. Wonderful presentation, awesome presentation about the lung transplantation, indication, contraindication, Indian scenario, etc. So over to Dr. Kanakavil sir for other moderation and question answer from the chat box.
Thank you, Dr. Soumitra. In spite of you traveling, taking all the pains to contribute for this important event. And
I am actually in the airport, sir.
Airport, yeah. Thank you.
I
Very
understand,
fantastic.
sir. On behalf of the IMA president and the state president and the entire member fraternity of IMA, we thank your commitment towards the cause in spite of being traveling. And in fact, I should appreciate Jayaraman sir, who have been following you up, and in fact, to collect the PPT and make your job much easier. And
Yes, sir. Thank you much for all the help.
And we look forward for more deliberations from you, sir, when you are comfortable. And I have a quick question, sir. Like many times, we have a fine balance between success and failure. In spite of your 200% or 300% effort in recovering these patients after a tough process of, I would say, surgical implantation or a transplantation. But after that, it looks like you have a humongous task of managing the rejections.
Yes, sir.
If you could briefly tell us, like, how important is the follow-up period of post-transplant in a minute or so, then we will let if there are any questions. We look forward to hear from you, sir.
Yeah, about the chronic, there are two types of rejections basically. One is the acute rejection and the chronic rejection. The acute rejections are perhaps easier to manage, but the chronic ones perhaps comes, as I have shown in my slides, that about 50% of the people will get it by the age of 7 years post transplant. So that is much more difficult to manage, and slowly that's the reason at about say 15 years or 18 years down the line, second retransplant for most of the patient who has undergone transplant in the younger age group, like a CF or like a congenital lung diseases. So this is the background. How do we follow up? We follow up the patients first 3 months extensively. First 3 months we try to follow them up at least once a week. We try to see them, and then after, if they are from Tamil Nadu, it is easy for us. If it is they are from other states, or many of them are from abroad also, we tell them, the other states and abroad people, we tell them to stay back in Chennai at least for a month after transplant, so that we can follow them up for about a month. And then after we will contact their local pulmonologist, and with this age of connectivity and WhatsApp and video chats, etc., things have become really easy for all of us. We can talk to the patient, we can talk to their the pulmonologist who is managing them, how things are. We want to see them at and do a bronchoscopy and thorough evaluation of a CT scan, PFTs, X-rays, mostly at about 1 month, 3 months, 6 months, 1 year, and then after once in every year. This is the regular follow-up. We must see them so that we are also on top of the things of how they are doing. All the others, we usually depend on their local pulmonologist who is managing the patient before and after the transplant.
I think the transplant is only about the initiation of the process of treatment. And I could see
basically,
the amount
sir,
of
it is a marriage. Basically, it is a
I
marriage
understand.
between
Someone
the
has
patient
to
and
work the marriage. That's the part of the pulmonologist being contributing. Thank you very much, Soumitra sir. Now I'll be very, very happy if there are any questions. There have been more than 60 people who have been always there. At the peak, we could see 150 people, close to 150 people joining us for this important evening event. I wish if there are any members who would like to ask questions. Kantimati ma'am, are you with us, ma'am? I think madam has left. So, madam, we wish to hear from you because you have been, I could see you have traveled all the way from home to your office at the Omandurar Transplant office at this odd hour. Thank you for accepting our request. And I wish
Madam
to
is
hear.
always there for all of us. So,
sorry, sir.
Whenever we need something, yeah.
So I would like to hear from Kantimati ma'am, the closing comments before I hand over back the task of closing session to Dr. Jayaraman sir. Madam, over to you, ma'am.
Yeah, it has been a nice discussion. I do not know whether your IMA members could follow the in-depth knowledge imparted by our surgical faculty here who have spoken on lung, heart, and kidney and liver. But I think some of the basic points they would carry back home. And what I would like to say is, it's a lot of work from the government side we work 24/7 to promote organ donation and for this disease transplant program. And so the least we can ask our people is that we can all, it is a form of awareness to pledge to be a donor, to pledge to be a donor is only a form of awareness. It doesn't mean that if you have a donor card, they're going to take your organs or anything like that. Any of your patients ask you, you can always say that. So it is just a form of awareness. That's all it is. And this is one way of creating awareness among the public. So that is what we are trying to do. And I thank the entire IMA team and Kanagave for pursuing me to be here. And thank you so much. Good night to all of you. Kanagave, I think it's too late. Many of them have left, I think.
No, ma'am. I could see the energy level. Still, the last person was speaking, because as we come to the close, only many are started leaving. And sir has recorded this program, and this sure will be shortly uploaded in the YouTube. Sir is very prompt. In fact, I should put on record. From the time he allotted the CME, every second day or third day, he used to give updates, what he has done, what I have to do. He has very meticulously curated the program, and he gave me full freedom for the entire program. Sir, it is your ball. You please plan a program so that everybody gets benefited. And I could see everybody immediately and instantaneously agreed when we proposed this to them. Not a single speaker withdrew, in spite of being at odd situations and odd locations. Still, they continue to speak. I wish, as Madam said, this takes up to every small medical practice or a hospital-based practice or an institution-based practice or a teaching center. If we could have given the knowledge to one new person, and that blossoms to a transplant, and then it blossoms to give a change in one human life and society at large, the purpose is done. I thank the president for allowing us to do this task. I thank Jayaraman sir. In fact, I proposed only last month, sir, I wish the academic committee considers our request to do 1 month program. He said, sir, next month we are doing, sir. That's all. He didn't even, I'm not sure how many thoughts he had in his mind for the subsequent month's program. He instantaneously accepted, sir, we are doing this month, sir. That is all. He never, I don't know, not even a mint of hesitation he had. That's the amount of commitment he has given us. And I'm sure this will benefit the medical fraternity and the society at large. Jayaraman sir, we wish to give the closing remarks to you, and we can call the session a close.
Yes, sir. So very good evening. We had a wonderful session on organ donation. So I thank you, Transplant Secretary Member, Dr. Kandipati Madam, for the wonderful elaboration about the transplant and what are the legal aspect, how do we get the organs and allocation and all. Very, very thankful, very, very useful to all our members and doctors, Madam. Thank you very much. And I thank all the faculties, Professor Mohammed Rela sir, and Professor Edwin Fernando sir, and Professor Paul Ramesh sir, and Professor Dr. Soumitra Sinharai. So they're all well-versed in this organ transplantation, indication, contraindication, and journey of the transplantation. Beautifully, they discussed in detail about that. So I thank moderator and the organ donation committee chairman, Kanagave sir, for the wonderful moderation, wonderful introduction of topic and discussion. So we have a painful message to meeting every speakers directly. Tell us our office, and the madam is a teacher. So very proud of you. The awareness is the need of the hour. Awareness is, we have to, IMA is doing all the wonderful things. We have a lot of more than 30 committees we have. One of the committees is organ donation and academic committee. So we'll do more and more programs to, sensitize our doctors first, then our general populations about the organ awareness, organ donation, etc. So thank you very much. We had a wonderful evening. I thank you all the delegates and our IT team chairman, Dr. Vijay Kumar sir, our technical team, Mr. Aravind, and all the delegates for a wonderful evening, wonderful update about the organization. Thank you very much. God bless. We all update. Thank you, madam. Good night. Good night, sir. Thank you.
Good night, everyone. Thanks very much for joining.